is Dr. Robert Hopkin. He has been coming to these conferences for at least 10 years. When was your first one? Minnesota. So 2011. So this is, yeah, a long time. Yeah, because I can remember talking to you in Tennessee, and Minnesota was right before that. Yes. So anyway, he has been a huge friend to the organization, always is so willing to come. And so it's always great. Even sometimes he'll just come and not even give a talk and just hang out and answer questions and just give us information. But anyway, I'm going to let Dr. Hopkin go ahead and get started.
All right. Thank you for having me here today. It's an honor to be here. And I know that I don't know what it's like as much as you guys do. You know more about this than I do, and I think that's really important. So today I'm going to cover a variety of topics, so I don't have one specific theme. Let's see if I can figure out how to do this. Okay. First, I wanted to address this question. So there was a question yesterday on if there is a test that didn't get done earlier because it wasn't available, can you get that done? And is there a benefit? So Dr. Scott discussed is there a benefit a little bit. And the answer is there could be. But then he said insurance may not pay for this. And I wanted to address that mode. How do you work with the insurance companies? So the first thing that you need if you want to get something done is a reason that it needs to be done. So if I say that my patient had a FISH test and I know they have 1p36 deletion syndrome, but I want to do another test because that's not the right test, and I want to prove that they still have 1p36 deletion syndrome with a $2,000 test, they're going to say, what? Are you crazy? You already know what they have. On the other hand, if I say to the insurance company, this patient with 1p36 deletion syndrome is at risk to develop cardiomyopathy, and I need to know if this specific gene, PRDM16, is deleted or not, because if it's deleted, they need an echocardiogram every 2 years, and if it's not deleted, they don't need that. So I will make a functional, care-driven decision. They're much more likely to agree to that. If they still don't agree to that, then I point out to them that an echo costs between $1,000 and $5,000, depending on where you live. And if we can decrease the number of echoes in this child's life by 2, it's worth it because you save money. Then they're more likely to do it. So just think about the reasons that you need and make it very clear when you're negotiating with providers or payers that you know why and that you will do something with that information. If you want it just for curiosity, then you need to find a researcher to do it for you. Okay? Because that's free. All right. On to the next topic. Models of care. So there's a lot of ways that we build the structure of healthcare. And Dr. Scott was talking about, he will see a patient a couple of times and then often just send them back to the pediatrician. And I said that I use a little bit different model. So I'm going to talk about both of our models plus some other ones. So the most common model for healthcare in the world is primary care director as the lead provider and the key coordinator and decision maker. And so with that, the primary care physician is the first person you go to if you have something that you think needs attention, and you work on that through them. They do what they know how to do, what they understand, and if there's something that they don't understand, then they use outside consultants. And that works really, really well for common things. So heart disease, diabetes, hypertension, things that lots of people have, that system works great. The primary care physician can usually get you started, and if the response isn't as good or the control isn't as good as what they want, and those are very defined numbers, then that's a great system. The problem with things like 1P36 is your primary care doctor doesn't know what it is, doesn't have any experience with it, they don't know what the goals are, so they don't know if they're doing the right things. They don't have any way of measuring that. So it's not as good for that. If you are lucky enough to have somebody who has an interest and the time to read up on it, it can still work. Okay. Next model, and this one is also quite common, is a specialty care focused model. In this, usually one of the specialists involved in a patient's care who takes the lead. So it works great for things like cystic fibrosis, where the main problem is pulmonary disease. The pulmonologist takes the lead on that. They learn the side issues related to that disease, and they then use other consultants where they need to. But what happens if you have somebody who has major needs in cardiology, neurology, gastroenterology, ear, nose, and throat, audiology? Then who takes the lead? And there are ways to do that, but it doesn't work as well. Now, if you are in a place, like in Cincinnati, there's only one place that kids are able to receive specialty care. And so we all of the specialists see each other on a regular basis. So we can talk to each other fairly easily, and that works. But many people aren't in a setting like that, and they might have to go to 3 or 4 different hospitals to get the care they need. And having one specialist who really only understands their part of the system is not going to be able to manage that very efficiently. So then what do you do? So alternate approaches. Sometimes there's a specialty in pediatrics that's relatively new called complex care. And there are some adult practitioners that also do something similar to that, but I don't think it's a formal specialty in adult care yet. But they can take the lead. Their job is to know how to coordinate and implement care plans for people who have many different needs. If you're in a place where that's an established practice, that's a good option. Multi-specialty clinics are a good option if you have enough patients being seen in an area that the practitioners involved all want to work together, and they hold a clinic on 1 day per month or 1 day per week, depending on how many they have, for that condition specifically. And we use that for things like craniofacial care and for relatively common genetic conditions, so neurofibromatosis or Noonan syndrome or Down syndrome. That kind of model is very useful. In that one, you need still case managers, and they are very helpful. In fact, I think that the nurses and genetic counselors who do the case management and tell you this is who you need to see, and they'll help you to get those appointments set up, are probably more valuable than the physicians on an individual basis. Don't tell anybody I said that, but it really is a service, and you can ask for a case manager in most large pediatric hospitals. They're really hard to get in the adult world. but it's worth asking for. So in Cincinnati, we noticed all of these things and the difficulty in keeping people plugged in. And we were sitting in a faculty meeting complaining about the fact that nobody gets it. And so a couple of us said, well, hey, let's try. We understand these syndromes. We live in the world of rare disease. Let's see if we can take a role in management, not just giving people the initial explanation of the disease, but continue to follow them and see if that changes anything. So there were two opinions on how that would work. One was that the families won't like it because that's one more doctor's appointment. The pediatrician won't like it because you're stepping on his toes. And the specialists won't like it because they don't want to be told what to do. And the other opinion was the families will probably like it because we actually know what we're talking about, and maybe the other people will put up with us. So we decided to try it. This was about 25 years ago, and we said, if somebody has a diagnosis, we will be the people who do the syndrome-specific care and coordinate that. And we started it, and within a year, we found that many of the families liked it. The ones who didn't just didn't come to us, which was fine. The pediatricians loved it because they felt like they were groping around in the dark and didn't have any idea what to do, and they didn't understand the rare disease literature because it doesn't come with guidelines. You get individual case reports and have to put that together. And the other specialists loved it because they could ask us to look up the details that they were missing. So we also did some testing. We took a group of pediatric cardiologists and adult neurologists, and we gave them tests on genetics to see what they knew. So what's your guess? So not much. So the pediatric cardiologists actually knew a lot about what the individual genes did for the heart. We were rather impressed with that. But they had no idea, even for things where it was well known, like they didn't know that people with Marfan syndrome have problems that aren't aortic root related, like retinal detachment and blindness, or scoliosis, or musculoskeletal pain, or respiratory problems. So we said, okay, maybe cardiologists aren't the best people, but the adult neurologists, they knew that genes were important, and that's about it. They didn't even know what those genes meant in their specific field, with the exception of the gene that causes Huntington disease. They all knew that one, but they didn't prioritize at all. And I think this is a problem. It's one that genetics needs to fix because we don't market very well. So any of these models that I'm talking about can work. If you like the system that you're in and you have people who are providing good care, you don't need to ask for anything else. If you are frustrated or overwhelmed with the complexity of the healthcare system, it is legitimate to ask for help in care coordination and to ask for access to specialists who may know more about it. You know, it doesn't have to be a geneticist, but you need somebody who's going to be the one who knows. That could be a developmental pediatrician, a neurologist, a general pediatrician, but you need somebody who's going to take an interest. All right, so why does this matter? I had a case that I was called about. Now, this is not somebody I saw, so there will be a lot of details I don't know, and some of the details I give might be made up because I'm doing the best I can, but I have to be careful in how I say this because this is a fairly challenging case. There was a child born number of years ago, and the child had low birth weight, wasn't eating very well. So the child ended up staying in the newborn hospital for a couple of weeks. The family were taught how to feed this child and do the best they can. And the pediatrician then picked it up on an outpatient basis. And for about 3 years, the pediatrician kept pushing the family, you've got to get more food in, you've got to get more food in, sent them to the GI doctor, and the GI doctor kept saying, you've got to feed more effectively, we need a surgery, let's put in a G-tube, this child must grow. Which is legitimate, because if you don't grow from the newborn period at all, you don't live very long. So they were worried, and it was a legitimate worry, but nobody had done anything. When the child was about 2 years old, somebody did a test, and they found that the child had 1p36 deletion. And that was explained to the family, but they only had one chance to sit down with the specialist. The geneticist explained what they knew, but admitted that they had only seen one previous child with 1p36 deletion, and so they read them a couple of paragraphs of a summary and told the family that they still needed to work on feeding as the main focus. And the family did that, and they kept getting more and more frustrated. And then when the child was about 4, they were reported for neglect. And I don't know if there was neglect involved or not, because I didn't know the family and I haven't seen the child. But that's pretty harsh. And the family then was ticked off, and they didn't trust the healthcare system, and they quit coming in. But they kept feeding the child, doing the best they could. And when the child was between 6 and 7, it had an acute illness and was really looking really sick. And the family finally just said, well, we have to go back to the doctor. And they went to the emergency room, and the child died in the emergency room. Now, this is a terrible story. And it gets worse, because this was an unexpected pediatric death. That's an automatic referral to the police for review, automatic requirement for an autopsy, and charges were filed. Now, I do not know, again, there are times when charges like that need to be put in. So why does the system matter? The system matters because if this child had stayed in the system and the death was inevitable, the family should have had support. The system matters because if there were things that could have been done, the family needed support and education, and those things needed to be accessed and implemented. The system is important because if the parents were not taking good care of the child, and there is a reason for the charges to be filed, something should have been done to intervene so the child got better care. And there are ways to do that. And I think we need to work on the system and make sure that that doesn't happen. It's a terrible story. It's a sad story. There are better ways to care for children. Now, I have had children that I've cared for with 1p36 who had similar beginnings to this and who died young, but nobody was arrested. Charges weren't filed. We sat with the family in one case while we were saying goodbye. And that's the way it should be. And we need to make the system, find the system, work on the system to get that kind of care. So as a result of that, I try to do follow-up. Now, I can't follow up every patient that I see, but we do the best we can. And that's why I think it's sometimes a good idea to go back to someone like me in genetics that maybe isn't going to be, you need a surgeon if you have a heart defect that needs to be repaired. It's not as obvious why you need somebody whose information is what we use. Okay. Now this child is not my first patient with 1p36, but she is the one who inspired me to commit to this. We walked in to see her. She was about 1.5 years old, and she wasn't walking or talking yet, and I looked at her and said, she's got something. And the genetic counselor who was next to me pushed me on the arm and said, she has 1p36 deletion. I said, what? I knew what it was. We had seen 3 or 4 kids by then with that, but I had not put the pattern together. And she was right. We did the test. It was the correct answer. And her parents went to find out what was known, and there was nothing available. So they held a series of fundraisers and raised several $1,000s and brought it to us and said, there needs to be a national distribution of a brochure on this. This isn't that rare of a condition. There is nothing appropriate for families. Please write something. So we did that. And that actually is how I got invited to come to this meeting and to be connected here. So I thank her every year at this time for helping, but that is really important. And we got that message because the parents spoke up, and you guys can speak up and ask for things. Now, you guys know most of the stuff on this slide, that all of these are important issues. The ones highlighted in red are things that I found advances on within the last 2 years since the last meeting that we were at. This is some more, and we're going to go through some of this in a little more detail, and then one more where there were significant changes in the understanding. Now, as you know, this is a highly variable condition. These 2 pictures, kids with the same thing, presumably. There's a big difference in how they're doing and in what problems we're facing. And that has been well addressed here. This is a picture of both the chromosomal analysis and the microarray on a group of kids. And as Dr. Scott pointed out, they're all different. Now, on the chromosomes, for patient 1 and patient 2, I cannot see the difference. Patient 3 and patient 4, patient 4 I can't either. Patient 3 and patient 5, I can see the piece that's missing, but it's not obvious. I don't expect that everybody in the audience can see that the chromosomes are a little bit different. But you can see that the microarray scale is different. And that makes a difference in what we're going to see, and that's why Dr. Scott said everybody in here has their own unique syndrome. But all syndromes have some kinds of variability. They're not as consistent as we make it sound, and only part of that is related to the changes, to the differences in the microarray. So we did a study a few years ago and looked at speech and language, and we wanted to see how the kids did. It was actually at the Great Wolf Lodge, and it was people attending this meeting that volunteered, and we assessed their children. And as we expected, there were a lot of communication problems. But what we hadn't expected was both receptive and expressive language were abnormal in every child that we were able to assess. That doesn't mean they can't communicate, but it means that there are some significant challenges. But expressive language was much, much more difficult for the kids. And I think that's an important thing for us to know, and it's a legitimate major focus. Working on communication, on expressive communication, starting before the child is a year old, certainly before they're 2 years old, it's easier to play keep up than catch up. Make sure you get plugged in and you work on communication skills. Now, the receptive language, you can see there's a lot more variability, but that's also a significant problem. The best thing you can do for that is talk to your kids, sing to your kids, get them to pay attention to you so that their brain begins to be programmed to communicate and to process communication. Okay, now I'm going to talk about some papers that I found that I thought were interesting and important, or sometimes just cool. This one is important. It's possible to pick up on this condition prenatally. In this case, 100% of the people in this study had abnormalities on ultrasound, and they could find things. So they had either nuchal translucency, which is thickening of the skin on the back of the neck, a brain malformation, most commonly polymicrogyria, or a heart defect. And they proposed that we should think of that the physicians should think of 1p36 if they see one of those abnormalities. Now, what do you think of that? Is that going to work? There are 8,000 rare disorders. Do we have to think of all 8,000 of them individually? No. That's not even possible. I've spent my whole life doing this, and I have not seen or heard of probably at least half of those conditions. There's just too much. So what should we do? We should make it so that people, if one of these things is found to be abnormal, that people are offered the opportunity to look into what it is so they can be prepared and know what to expect. Okay, so it's a little bit different, but that approach, offer a microarray, will pick up 1p36, 22q, 16p11, and the 100 or 200 other known microdeletion syndromes, and help all of those people, including the people with 1p36. Okay. Another thing that I think is really important, there was a group in San Francisco that a child was born, and they thought initially that the child had hypoxic ischemic encephalopathy, which led to brain damage and a diagnosis of cerebral palsy. And later, when the child was a couple of years old, somebody looked at the child and said, "This child looks a little different." And that's when they did testing. And then they were embarrassed because they had missed it. And so instead of just trying to hide that and forget about it, the leader in the genetics group felt bad, and she said, "I wonder how many times this has happened." And so they gathered up a bunch of cases, 69 infants with 1p36 deletion. Most of them required neonatal resuscitation. Hypoxic injury was thought to be a part of it in about 75 to 80% of cases. And they even had the brain MRI findings that we think of as going along with cerebral palsy. So, one of the questions that they asked is, should we offer genetic testing to everybody who has a presentation that looks like cerebral palsy, and if we do, what will we find? Their thought is that we would find an increased likelihood of 1p36, and they're undoubtedly right. When I was in medical school, they thought that 1% of cerebral palsy had a genetic component, but that has changed pretty dramatically. In the last 5 years, they've looked at this a number of times, and it's at least 15%, probably closer to 30% of cerebral palsy is related to a predisposing factor that makes the kids more likely to have birth trauma. One of the important players in that is 1p36, so we should expect that. And if you have a prenatal diagnosis, you want to plan the delivery accounting for that increased risk, because the last thing you need if you have 1p36 deletion is additional injury to your brain. So I think that's an important one. But the other thing that's important is it means that some of the problems that we see in some of the kids with cerebral palsy were going to be there anyway. And we need to accept that and not necessarily look for blame. Okay. The question was asked yesterday on translocations, and if there is one. So the slide previously that I had that had translocations on it in red said 3%. This is a 2020 study, and they found that 7% of the kids with 1p36 had a translocation of some kind involved. That makes it an important contribution. Now, I've had, I think, 3 or 4 patients in my clinic with 1p36 deletion who had a translocation. All of them, the 1p36 deletion was the thing we could recognize clinically. It kind of pushed the other chromosomal abnormalities to the background, but the problem list that they had included both of the chromosomes. So we need to know the details, not just that a child has 1p36, we need to get the microarray, we need to know which genes are involved, we need to know if there are other chromosomes involved to take best care of the kids. This one was on psychiatric things. This was a very simple report. There was a child who was having a lot of behavioral issues, and the psychiatrist involved wondered if there was anything that they could do. But they saw the child, they said, wow, this kid has no attention span, and they treated the attention deficit. And the child wasn't sleeping at night, and they gave melatonin, which is not a sedative. It tells your brain to prepare to go to sleep, and then if you have good sleep hygiene, many children will go to sleep sooner. They may not stay asleep longer with melatonin, but it helped this child. And then they had complex behavioral problems and got neurology and psychology and psychiatry all to meet together and put together a plan, and it worked. And so they thought that that in and of itself was new enough and important enough that that should be written up, because if you take the problems that there are treatments for and you treat them, the kids do better. Now, the thing is, it's not surprising that people think that it won't work, because if you read especially some of the early reports of 1p36, the things that it's compared to are diseases or conditions that we think have very little opportunity for improvement. And in the early months of a child's life with 1p36, they look very similar to those conditions that have profound developmental disability. But in the long term, they don't. In the long term, the kids with 1p36 make more progress than some of the other things that it has been compared to. We need that information to be recognized, because I still have people call me occasionally and say, well, we met with the geneticist and the pediatrician and they said there's nothing we can do, so good luck, do the best you can. That's just false. It's not true. There are lots of things we can do. You pick the problem that's the most important now, and you do, if there's not something specific to 1p36 that's been approved for that, then you use the things that you would use for that problem in other settings, and you keep trying new things until you get the progress that you need. Okay. Now, 1p36 is a big chunk of chromosome 1. It has over 300 genes in it. Yesterday, Dr. Scott talked about the distal critical region and the proximal critical region, and those have about 100 and almost 200 genes in that region, if you take both of them. And the kids look and act very similar from both of those two critical regions. But this paper says that there's another more proximal deletion that's different. These are the pictures from that paper. Now you will notice, I don't know if you can see this, right here is the deletion they're talking about. It's quite small. This is the proximal critical region for the more well-known 1p36, and this is the distal critical region. So this is a distance away, and there are, some of the things are the same, but there is some difference. This is a second family that was published, which means there are a total of seven cases published. One of the big differences is that speech is a relative strength for this deletion, and that the motor delays are mild. There is still a cognitive disability, but it tends to be mild to moderate. So the question that I was thinking of when I read this is, well, do they fit with the 1p36 deletion? And do I have any of them? So I went and looked. I did. I have one here. I have another family that I'm pretty sure has the same thing. But I was unable to find their charts when I was writing this talk. So this is probably not as rare as it's been assumed. It just hasn't been found and written about. So the world of 1p36 has expanded. That can help you in advocacy. And the variability is really big, even bigger now. This is another new condition that's 1p36 related. This is a duplication of the proximal critical region. And it is associated with something that had already been described, Setless syndrome type 3. And it has, one of the key features of it is some scarring on the temple area of the head. But it also has cognitive disability, seizures, eye malformations, other things. Now, why is this important for people who are in this group where the focus is 1p36 deletion? Well, this has implications for a couple of things. One, it gives us a little bit more information on what the genes in 1p36 region do. And two, it indicates that if we do find a way to replace some of the genes or the gene functions in people with 1p36 deletion, that we're gonna have to be careful. Because if you get too much, there's problems. So you have to be able to regulate the therapies well. This is another one. This one is on a tumor. They took some tumors and sequenced the genes in the tumors, and they had deletions of 1p36, and some of them also had point mutations in genes, and they found that KIF1B beta, and I don't know how to say the next one, YME1L1, interact with each other, and in doing so, they keep cells alive. And that's the way they're supposed to function. It helps with energy metabolism. Now, the YME1L1 isn't going to be deleted in your kids because it's on chromosome 10. But the KIF1 beta is on 1p36. But if you take out the KIF1 beta, then the other one can't do its job either. Now, there may be ways of helping with that energy metabolism. That gives us a target that we can look at for possible interventions. We're not ready for it yet. And some of this, what I'm talking about right now, as an example, I am admittedly making this up. This is my opinion, what I am taking from these papers that have been published, but I want you to know that this stuff is important. Is important for you, is important for your children. This is another one that's a similar one, but this one, both of the genes mentioned are in 1p36, so we've heard about RERE yesterday because Dr. Scott has been one of the key drivers in understanding that gene, and it causes some brain problems. But the people who did this study looked at this, and they found a small deletion, or a small duplication. Now, you will note, if you read the words on the slide, that it disrupted RERE and ENO1 because the breakpoints were in the middle of the genes. So it's loss of function. Even though it's a duplication, it's loss of function of these two genes. And the models that they did with this, the rat models, they found had brain malformations. And the person that had the duplication had polymicrogyria, so they concluded that loss of function of ENO1 may be a driver for the polymicrogyria, which is one of the more common brain malformations in 1p36. Now, I don't know how we can directly use that, but it's a step forward in understanding. And the more we understand, the more likely we are to make the right decisions about what to do next. And the better the outcomes are likely to be. Okay, this is just an update that wasn't mentioned on RERE. It also contributes to cleft lip and cleft palate. And we'll just say enough there. SPEN, we talked about a lot yesterday. I wanted to add a little bit more. You saw some of this information yesterday and heard that this specifically causes increased risk for obesity in females. And how confident can we be that that is actually biologically driven Or is it just that females gain weight easier than men? Because the female body, in all men and women, the female body has a little bit more fat on average than the male body. Because women need stores because they use them to feed babies and carry pregnancies, and that's important. So they looked at this and looked at the changes caused by the SPEN mutation. And if you will notice over here, all of these points of data are clustered. There's no way to distinguish this is looking at methylation of the X chromosome, and there's methylation in men and women of the X chromosome, but it's not different in the men for either of the two control groups compared to the SPEN mutation. Over here, you will note that you have the two control groups sort of clustered together in the women, and there's no overlap with where the methylation pattern was for the women with SPEN mutation and the control group. So that was some biologic evidence. So they went and got a much bigger control group, which is on the other side of the slide, and you can see that, again, clearly the females who have loss of function of SPEN have a different pattern. Now, methylation is something that is attached to DNA, and it turns on or off genes depending on the pattern. And this means that the gene function on the X chromosome is going to be different in women but not men for this gene. That is another place where there is a targetable potential if we can find out which genes are misregulated on the X chromosome and whether any of those have any impact on the tendency for weight gain. Okay, this is another gene on 1p36, ARID1A. It's associated rarely with a condition called Coffin-Siris syndrome, and that's usually due to a loss of function, which means people who are deleted for that gene should have that same thing. This is these are pictures of a little girl who has loss of function mutation in that gene only, and she had developmental delay, vision problems, abnormal dentition, poor feeding, poor growth, sounded a lot like 1p36. This is another, we're probably up to at least 10 genes that we know play a role in this. Now this is another one where if you get too much, it's also bad. And in fact, in this case, if you duplicate this gene, as in this young man, it's even worse than if you lose the gene as a single gene being lost. In fact, this guy was worse than most of my patients with 1p36, and he only had a duplication, a small duplication with mainly this one gene in it. This tells us something. This is another gene that regulates other genes by epigenetic markings. We don't know which genes yet, but we need to work on that. Part of the message here is that epigenetics is important in 1p36, that we need more information about that. Let's see, and this is yet another one. So this one is looking at epigenetics, and this is another tumor study. You may be wondering why I keep picking tumors. And the reason is that research for cancer is much better funded than the research for developmental disabilities and multiple malformations. And that means that the cancer research, as far as what genes are important, is about 15 years ahead. But that gives us an opportunity, because if we can look at the genes that they are finding are important in cancer, a lot of those will be also important in 1p36 if they're in that region. And the medications that they use in cancer to regulate those can sometimes be important. I haven't seen any direct applications to the genes in 1p36 that we're stealing from cancer, but there are a number of other conditions where we're taking the approaches that were used for cancers, changing the dose of the medications, and finding that it's very useful in the syndromic situation. So this is worth paying attention to. And this adds 2 more genes, SRARP and HSPB7, that we should hope Dr. Scott gets a phone call for. Because even if he doesn't have one yet, he should. And this is something that he could add to his research cohort. So what have we learned? One is 1p36 is complex. We know enough now to make some suggestions. This list of suggestions is some of them things that I've pulled out from my reading and my experience. Some of these things are things that were mentioned by other people here, and there's probably more. So every child with 1p36 deletion should have an echo. If the deletion includes PRDM16, they need more than one. In fact, they need to continue having echoes throughout their life. But if they don't, then we can stop doing the echoes. For hearing, vision, speech, growth, mobility, scoliosis, and seizures are common enough that every child should be monitored for those things. Females are likely to have excess weight. We think, but haven't studied it yet, that males are probably more likely to have decreased weight and have difficulty growing and gaining weight. And we need to pay attention to that as well. We need to do those studies. Children with 1p36 deletion need a medical home, and most of them will benefit from coordinated care if we can get that. I will tell you that hospital administrators are generally resistant to that because coordination of care is not a billable service and it costs money. But it saves lives, it improves outcomes, and in the long run it probably saves money because you need less interventions if you stay on top of things. Epigenetic changes are clearly important to the understanding of 1p36, so we will need to do more interesting research on that. And there are at least a few targetable pathways that we need to learn more about and move this forward. And I'll stop, and if you have any questions, I'm happy to take them.
And also, if you have any questions, Dr. Hopkin is going to be here this afternoon for more of the roundtable Q&A discussion. So we might want to, unless there's some pressing ones right now, write it down, remember it. Write it down, remember it, because then you can answer those questions then. Thank you.